Hi, everyone. I hope you're all having a nice Wednesday afternoon. Welcome to this session number 3 in our series on the ethics of the COVID-19 in the Nordic countries. My name is Truls Petersen. I'll be chairing this session. I'm a member of the Nordic Committee on Bioethics, and I work at in the Secretariat of the Norwegian Biotechnology Advisory Board, which are the two organizers of this particular session number 3. For those who haven't watched the previous ones, you could find them online on YouTube on the Nordic Committee on Bioethics YouTube channel. Now, Jonas, if you could share my slide. The program for today, we have 1 hour. We will start off with a keynote by Reidun Førde, which I will present soon. And then we have one commentator from Finland and one commentator from Iceland. We will have some minutes for a Q&A at the end, and then you can post your questions. For those who follow this stream on Vimeo, you could use the Vimeo chat, and for those who follow the live stream on Facebook, you can use the comment field on Facebook, and I will read out the questions for you. Please say who the question is for, if it's for one specific person or if it's for the whole panel. And you can choose to state your name if you want to or not. Now, the organizers are it's the Nordic Committee on Bioethics. A few words on the committee. It was founded in 1989. The mandate is to promote Nordic cooperation, exchange of info in the area of bioethics. It's a pretty broad mandate. It is managed by Nordforsk, and our work consists mainly of organizing conferences, 2 to 3 conferences annually. The members are come from multidisciplinary background. There are 2 members from each Nordic country: Denmark, Finland, Iceland, Norway, and Sweden. And then we have observers from Faroe Islands and Åland. The committee also published an overview of legislation on biotechnology in the Nordic countries. The second host today is the Norwegian Biotechnology Advisory Board, which is an independent body appointed by the Norwegian government. There are 15 members, and as with NCBio, there's a cross-disciplinary background among the members. The aim is somewhat similar as the mandate for NCBio. It is to evaluate and discuss social and ethical consequences of modern biotechnology. And the advisory board addresses both issues regarding humans, plants, animals, and microorganisms. And the board should also advise the authorities and inform and promote public debate. Now, here's to the program again. Let's go to our first and welcome our keynote speaker, Reidun Førde. Reidun is by background a medical doctor, and she is professor emerita in medical ethics from the University of Oslo. The reason she was invited was that she was part of a working group that gave advice to the Norwegian government on priority settings for the COVID vaccine. The group published their statement, their report in November. And among the things it says is that the advice is it's a dynamic approach. So we are very excited to hear how these advices now compare with the later developments. So Reidun Førde, the screen is yours.
Thank you for this opportunity to share an exciting work with a lot of colleagues in the Nordic countries. To talk about and even to do resource allocation work is challenging in very many ways, theoretically, practically, and it very often causes disturbances, fierce discussion, which we think is part of the justification for the work. And allocation of vaccines is another contested issue. In the pandemic, that is to say the Norwegian politicians and the Norwegian health authorities knew early on that a vaccine would be vital for people at risk. So there was a lot of things at stake here. And because of this, the vaccine would be vital to open up society. And accordingly, a vaccine would be vital for the nation's economy. And we also knew that early on, there would be too few vaccines to cover the needs. But I can share with you already now that when we started this work, we were quite optimistic. We thought that the shortness would just last a few weeks, that we would sooner or later, and rather sooner, have enough vaccines, which has proved not to be the case, at least not in Norway. But we knew then that who should receive vaccine first would most likely cause disagreement. So accordingly, the discussion of who should get and who should wait should start early. So the Public Health Institute, which is an important bureau for advising political decisions in Norway concerning health and health policy, they appointed a fast working group. They called it an expert group in ethics and priority setting. And we were appointed in early September. And as you can see of this picture, it was multidisciplinary, but all of us have been working with ethics and priority setting issues for many, many years. And also, I can share with you that the conclusions we agreed on were true agreements. There was we agreed on most of the, or all of the conclusions. You can see also that Søren Holm is working as a professor in Manchester, UK. He's Danish citizen. And Gry Wester, on the last one on this list, she's presently staying in UK. So we thought that these two perspectives from abroad was also they were important and interesting. So this was the first group established that I know of, at least. And of course, ethical aspects is one of many considerations. There are economic, there are political, there are more clear medical, immunological, and so on and so forth. So this was one of many people working and adding to the final suggestions. But the plan was that to make a report sent to the Norwegian Institute of Public Health, which then makes its final recommendations for prioritization. And then the conclusion from the Norwegian Public Health goes to the Ministry of Health and Care Services, and then finally to the Norwegian government, which makes the final political decision. So it's a stepwise thing. An independent working group, which we were, in my opinion, it secures transparency of values underlying political decisions, and also, because it came early, allows for a public debate, which I think is extremely important in difficult fields like resource allocation. So I think that this could be a model for other difficult societal dilemmas as well. Very often the values are hidden in other considerations, but now by this working group it was made explicit. At least we attempted. Now, lack of knowledge. We started, as you know, in I think the first meeting was in late September. An obvious challenge for us was to the lack of exact knowledge in very many fields. We didn't know much about the effect of the vaccine. Effect on what? On serious disease, mortality, or on the spread of the virus? We know more today. On whom? Population group, how long it worked, whether 1 or 2 doses would be necessary, the logistics of the vaccination, how is the vaccine, how can it be distributed? Norway is a big country with a spread out population, long distances, that was a consideration. And also, of course, the development of the pandemic. The risk groups, new mutations, societal changes of relevance, geographical spread of the virus, and so on. And we see already that all these things are relevant when landed on conclusions. So, despite lack of knowledge, we had some things to lean on, and that was, we already have a framework for health priorities in Norway, more or less the same since 1987. A seriousness of the condition, effect of the intervention, and the relationship between the effect and resources used. So these 3 should always be considered together. And it was important for this working group that these principles could be carried through our recommendations as well. Then we had some existing guidelines for priority setting already in Norway for the swine flu, But then, of course, we saw that this pandemic affected older people not the same as the swine flu. So we discussed in the start, what about values? Very often values are just a nice spread on things. It's kind of living its own life. How much emphasis should we put on values? And if we work with values, they should carry through the whole document. And of course, we could list up a lot of different values, but we landed on these 5. Equal respect, the fact that all human beings count equally, and that morally irrelevant or discriminatory criteria should be excluded. That's a basic value in our society. Then another one was welfare, but in this are the old Beecham and Childress principles of beneficence and non-maleficence. Welfare is based on a duty to do good to others and reduce harm, to vaccinate those who benefit most from the vaccination. And then equity. Where possible, one should seek to reduce inequity in health and welfare. That may be compared to the principle of justice. And a special attention on the worst off in society. That relates to solidarity principle. So we also emphasize trust, which is very important in a pandemic and dealing with a pandemic, as we have all seen. And closely related to this is voluntariness. And then finally, legitimacy. Recommendation based on best evidence, shared values, transparency, and so on. So going from values to goals, that was an important part of the discussions. What are the goals of these vaccines? It should reduce the risk of death first, and then the risk of severe illness. These are closely related, of course. And by doing this, maintain essential services and critical infrastructure, protect employment and the economy, and then reopen society. But this is a hierarchy, and the most important goals are the first two. As I said, direct reduction in the risk of death may have the indirect effect that society can gradually return to a normal function. Measures, we didn't write much about measures, but of course there is a discussion about what should count, the number of deaths or years of life lost, healthy years life lost, which are, this is important in resource allocation in general. But in our view, there is a difference between prioritization of vaccines, in which there is more a societal, a much wider scope, and when we prioritize treatment of disease. So we landed on 3 categories of prioritized groups. Going from our values to our goals, it was obvious that people with medical risk factors were prioritized high. Old age and people with certain underlying diseases. If we didn't do that, we overloading the health service. And we also said that socially vulnerable persons may also have higher risk, but we didn't take that any longer than give an example of asylum seekers with no rights in a society, maybe one particularly vulnerable group. Then geographical variation. Major outbreaks may occur in densely populated areas, and we have seen that in Norway. We have had major outbreaks in areas with a lower socio-economic population, strong populations, and some communities or spread out areas hardly have any outbreaks. And then the third category was occupational groups that have an increased risk of becoming infected and or infecting others, and that are important to keep a society going, including healthcare. This geographical, the government landed on our suggestion of prioritizing the people at highest medical with the highest medical risk for death and severe disease. And age, of course, is a important risk factor here. But then not much has been said on our what we suggested, that you could consider areas with a high area of corona, and then give them the vaccine first. That has not been the suggestion of the government, but this has been criticized, and you can see here from the biggest newspaper, or an important newspaper in Oslo, where they said that in Oslo, 25 doses per 1,000 inhabitants has been given, compared to almost 50 doses in a area with no COVID at all. Now, we also have seen that this changes very quickly. So yesterday, an area with hardly any COVID suddenly had several, and with them in British mutant. What has already been said is that we were aware that things could change, as you saw from one of my first slides. So we emphasized a dynamic model, that the strategy and the prioritization order should be adjusted in line with the pandemic. And it should take into account the course of the pandemic, the properties of the vaccines, and the infection situation in Norway, which was, we didn't know enough of that when we finished our work. So the priority order should be adapted to each individual scenario. So, what happened? Yes, there has been a lot of media attention, more than I actually expected. So this was in the television, radio, newspapers, the very day that we finished our work. And of course, it was criticized. And especially, I think, the people, our colleagues in hospitals working with the COVID patients in intensive care units, they were quite mad at us, because they felt that they, who was working and could be affected, should be prioritized first. What happened was that with the news from new virus coming in, and at the time when we started our work and even finishing it, things looked quite peaceful in Norway. But then we had the second wave, and then the government decided that healthcare personnel working close to these patients should receive vaccine together with the most vulnerable groups of patients, that is, the oldest ones. But I think there was a great acceptance and trust from the authorities and from the media and from the public. Mainly, I was kind of surprised how it was welcomed, our conclusions. Of course, the economists also argue that it was wrong to prioritize old people in their last years in a nursing home, and sacrificing economy of the society. But to that is to say that there is no contradiction between these two aims. By keeping the number of deaths and seriously ill people down, as I said in the start, we also believe that society as a whole would function better. Yeah, thank you for your attention.
Thank you so much, Reidun Førde, for kicking this off. Now I am personally excited to hear if this way of working is typical for the Nordic countries or not, and if we have some of the same debates, or if the ones in Norway are very local and not typical. Well, to find out that, we will first hear from Iceland, sorry. Sigur Kristinsson will give some comments. Sigur is a professor of philosophy, specializes in moral philosophy, applied ethics, and bioethics at the University of Akureyri in Iceland. Sigur is also the chair of the Nordic Committee on Bioethics. So welcome, Sigur, and the screen is yours.
Thank you very much. I will start by sharing my screen with you. So yes, I am very thankful for this opportunity, and I'd like to thank Reidun Førde for this very interesting and inspiring account of the difficult work, and in some ways courageous, as she pointed out, because this is in the public eye very much, and great interests at stake, with that she and her colleagues have done. I'm of course also grateful to the Nordic Committee on Bioethics and Norwegian Biotechnology Advisory Board for this opportunity to comment. Now, I will first say a few words about the expert group report generally, and then raise a few critical points for further reflection. Some of them have to do with the report itself, but some then sort of raise further issues about vaccination. So it is commendable that the Norwegian Institute of Public Health commissioned a report by an expert group on this issue. It's easy to agree that knowledge and expertise and professionalism are crucial for our hopes of dealing successfully with this pandemic. It seems clear that countries that have been relatively successful in this regard have enjoyed a trusting relationship between government, experts, professionals, and the public. But lack of success, on the other hand, correlates with the opposite: distrust and misinformation, informational chaos, lack of unity and solidarity. It's not enough to have just any experts, though. It's obvious that expertise in epidemiology and other health sciences is essential for dealing with the pandemic. Expertise in economics is of course also very relevant. But expertise in these areas does not imply expertise in ethics and prioritization. And this fact is clearly acknowledged by the composition of this 7-person expert group with 4 philosophers, 2 in medical ethics and clinical ethics, scientists. When it comes to reasoning about ethics, values, and priorities, the sort of expertise represented in the group is of crucial importance and complements the other essential expertise required to deal successfully with these enormous challenges. Norway's example is a stark contrast with the fact, for example, that in the United States, no national bioethics commission operated during the Trump presidency, which also extends expertise generally. The sort of approach exemplified by Norway is important for earning trust from the public, as well as democratic legitimacy. Recommendations are clearly communicated based on clear and transparent arguments. The group in the report articulates 5 foundational values: posits 5 goals that serve these values and defines 3 priority categories for immunization. The report also explains how the vaccination strategy, including the prioritization order, should be adjusted over time in line with how far the pandemic is under control. In other words, the priority setting should not be static, but it should be dynamic. Now I move to my sort of more critical discussion or points that I would like to raise. My first point concerns the priority categories. They are defined as risk factors for severe illness, infection situation, and occupation. The first is certainly well motivated by prioritizing direct medically relevant risk factors, age and underlying conditions, who are likely to prevent more deaths and severe illness. And these goals are appropriately ranked number 1 and 2 in the report. It was less clear to me how the argument goes for the priority of the second subcategory, that is special groups. The report states that these include socioeconomic groups overrepresented among those with a severe COVID-19 disease course or hard hit by infection control measures. It's the second part of this statement, that makes me pause a little bit, because infection control measures hit people by imposing burdens that are typically not medical in nature, but economical. So economic compensation would therefore seem appropriate. Now, perhaps the thought is that by vaccinating early on people in certain occupations so that they can start earning their living again. But in that case, the categorization seems confusing because category 3 is occupation and category 1 is risk factors for severe illness and death. So not being allowed to work is of course not best described as a risk factor for severe illness and death. My second critical point here concerns the recommendation that if the infection burden shows large differences between different geographical areas in Norway, geographical prioritization should be considered. If I try to imagine how a recommendation like this would be received in Iceland, I can only foresee serious practical and political difficulties and debate. But maybe I'm too pessimistic here, and maybe these kinds of this would not arise in the same way in Norway. The third point concerns people in critical societal functions. I just sort of want to raise the question of a potential for abuse and controversy if these functions are not defined very clearly in advance. So maybe we're thinking about police, for example, and frontline workers generally. And then, I mean, these are relevant occupations, but that have to do with spreading the disease and reducing risk factors also for as an indirect consequence for serious illness and death. But the kind of controversy I have in mind would arise if government would decide that they are more important than others, or the latest example, the urging that Olympic athletes be prioritized. Now on to the values. These are all crucially important values, although others might be mentioned. Equal respect implies non-discrimination. Welfare implies directing efforts where they will have the greatest benefit, both individually and collectively. Equity implies fairness and regard for the disadvantaged. Trust requires competence and integrity. And legitimacy implies transparency, evidence, and democratic procedure. My critical questions here concern the point I already mentioned about geographic priorities, and secondly, that the value of welfare leaves it open whether welfare is to be maximized or harm minimized. So maximizing total or even average welfare in society might not be achieved by the same strategy as the goal of minimizing death and severe illness. The RAND goals do seem to make this clear, though. The goal of minimizing harm becomes before other goals. Now, similarly, equal respect and considerations of welfare might not result always in the same recommendations, but I will not pursue this question further here. But now I want to move a little bit sort of beyond the scope of this report, from the intranational level to the international level. Solidarity is a value that comes to my mind when I think about this issue. It refers to the value of helping those who need it most and are least able to help themselves. And solidarity is in the report discussed under the heading of equity. Although solidarity is not the word that is used. The aim is to reduce inequity, for example, by providing immunization free of charge to the entire Norwegian population, and to pay attention to the most disadvantaged in society, such as undocumented immigrants. My critical question is simply this: is the priority of Norway over other nations thereby assumed? And the same question would apply to any other nation, of course. It's not Norway in particular. Is it okay for us to, at this stage, think about our own first, or only on our own? Now, one of the 5 values the report draws on is equal respect, and the quote says, the report says, in a direct quote, all human beings have equal moral status, and therefore their interests are deserving of equal moral consideration. In practice, this means that vaccines should be prioritized in line with morally relevant criteria, and at the same time actively exclude morally irrelevant or discriminatory criteria. Criteria that violate equality are, for example, skin color, religion, income, and social status. I would like to add that from the standpoint of humanity, nationality could easily be added as a morally irrelevant criterion for whether or not your moral status deserves equal respect. Now, recently, Tedros Ghebreyesus, the Director General of the World Health Organization, reminded us forcefully about this moral concern, that we need to keep our scope of moral concern open and wide. I need to be blunt, he said. The world is on the brink of a catastrophic moral failure, and the price of this failure will be paid with the lives and livelihoods in the world's poorest countries. The problem is that we lack international authority that would secure coordination when it comes to securing and distributing the very scarce resource, at the moment at least, of COVID-19 vaccine. Now, Thomas Hobbes, who wrote the Leviathan back in the 17th century, he theorized that when there is competition for scarce but vital resources and no supreme authority to check the self-regarding acts of individuals, the result will be a state of war, and in his own words, this results in continual fear and danger of violent death, and the life of man solitary, poor, nasty, brutish, and short. The Secretary General simply pointed out that we are seeing increased vaccine nationalism, as he calls it, bilateral deals that bypass a more wider international agreement. And he asks us, is it ethically defensible to vaccinate healthier adults in rich countries before health workers and other people in poorer countries have been vaccinated? Will the pandemic be defeated without international solidarity? And what is our responsibility? So I will just leave the discussion now with these questions. Thank you very much.
Thank you so much, Sigur. Let's just move onwards with our next commentator, which is then from Finland and the University of Turku, and that is Helena Siipi. She's also a philosopher, an adjunct professor, and a university teacher. So, Helena, the screen is yours.
Thank you. Thank you so much for inviting me. I have really enjoyed both reading the report and hearing the presentations today. It has been really interesting. I would like to start by saying that generally speaking, I found the outcomes of the report, the goals and the priorities set really good, and I don't have much critique regarding them. My point will concern the kind of be more like theoretical or methodological, and concern more about the question of how do you justify an ethical advice. And while reading the report, I was happy to note that the advisory group is very clear about how they are doing this. They are stating that the advisory group has proceeded from values, the goals, and lastly to priority categories. And they are stating this in several parts of the report. So the idea is to start from values, come to goals, and then the priority categories. Of course, in this kind of value-based method, if you start from values, selection of the values is really crucial and really important. And again, of course, the advisory group is very aware of that. They state that the individual and the social perspective often align, but not always. Therefore, it's even more important to define the values that will govern the priorities. The ethics advisory group has argued that the following 5 values are particularly important for the coronavirus vaccine priorities: equal respect, welfare, equity, trust, and legitimacy. However, while reading the report, I kind of started to wonder why these 5 ones. Of course, I agree with the 2 other speakers that, of course, these are central and very important values. But there are other important and central values too. I mean, like, why these 5? Why not justice, autonomy, honesty, transparency, integrity, freedom, fairness, courage, caring, or something else? And this was something I was kind of wondering. Other issue that kind of wasn't crystal clear to me is how do we come from these goals, these values to the goals? How do the goals follow from the values? So the values of the advisory group, they say that they lead to the goals, but how? Or could some other values, maybe values of truth, knowledge, life, diversity, protecting the vulnerable, or solidarity, would they have led to the same goals? And while asking these questions, I also started to wonder whether there is a kind of alternative approach to these issues. And I'm not saying, of course, I'm not saying that the approach adopted by the advisory group is bad or wrong, but I'm kind of suggesting that there might be an alternative approach. So my suggestion is that it might also be possible to approach the issue on a kind of goals first approach. Because I'm asking, are goals actually more clear and self-evident or somehow better understood than values in the coronavirus vaccine context? If you go to a street and ask a layperson what should the goals be, my guess is that they might come quite close to the ones set by the advisory group. But if you go and ask the laypersons what are the values, it might be much more diverse. I also kind of made a small thought experiment, started to wonder if the advisory group starts from the values, and the values lead into something really strange, like we should vaccinate the dog owners or people with long hair first, what would happen? Probably they would go back to the values and kind of decide that we have selected wrong values, we need to change them. So in a sense, the goals are a test that the right values are selected. So I claim that often we know, without contemplating from values, that reducing the risk of death and the other 4 goals of the report, we know them without contemplating from values. We know already that the risk of death is ethically important goal. We may be even less certain why is that, and very often we are even less certain how the values behind this goal should be interpreted. The situation I'm suggesting, or the kind of alternative approach, is not uncommon in ethics. It's quite usual, actually, that the goals are better known than values behind them. This is kind of a situation when we are facing the challenge of justification. We know what is ethically right, but we don't really know why, or at least we have, if you don't want to talk about knowing in the context of ethics, we have kind of shared view on the issues, but we don't really know why is that. So other examples might be organ theft, death penalty, or human cloning. With respect to them, we have kind of, at least many people have a strong view that they are morally wrong, but if they are challenged, made to kind of tell why is that, they are much less certain about that. And I might go even as far as suggesting that the situation of the corona vaccination is somehow similar. We have a better idea of the goals than values behind them. Of course, at the same time, I really appreciate that the values are discussed in the report. Of course, I'm not suggesting that they are irrelevant or something that should have been left out. Of course not. I think that it's very good that they are discussed in the report, and their role is really important. But it might also be possible to read the report in the way that the values actually help setting the priorities between the goals. And as we heard, the goals are in the priority order, and I think the values are really important here. And the values also clarify the goals, especially they clarify that the goals will be attained in fair, just, and non-discriminatory ways. And the spelling out the values may also diminish conspiracy theories or other critical voices regarding the goals and priorities set. Finally, there is a small picture indicating that I feel that often the ethical reasoning is not straightforward from values to goals and to priorities, but actually the process is much more complicated. We are not only coming from top down, so to speak, we also go from bottom up or proceed horizontally, and we go one way and then we decide that we have to go back, and as you can see, the arrows have 2 heads in the picture, and actually I even think that there may be some arrows missing. There should be an arrow from value A to code 3 and so on. So it's not only top down, but also other ways. So thank you so much for inviting me again, and I have really enjoyed. And let me stop by saying that generally speaking, I really appreciate the work, the report, and I think that the priorities and goals are very, very much the right ones. Thanks again.
Thank you, Helena. I think we could start off with giving a word back again to Reidun to hear if you'd like to comment on both of them.
Yes, but thank you, both of you, very much. I really liked your commentaries, and I agree on almost everything. So I'll try to address some of it. Of course, you raised some very big issues, and Helena, you showed rightly how complicated this work is. You really go back and forth. It's not one straight line. You adjust and you discuss, and that's the beauty of this process, I think, too. I didn't say in the start, I believe that this work has, I don't think other than Germany, any other countries who have started up their resource allocation and vaccine allocation work by in this way, by making the values or asking people who work with ethics for an advice in the start. And I'm really I don't agree on everything that is done politically, but I'm really happy that they did it this way. So Helena, you first. You said why these values and not other values, and why didn't you start with the goals? Well, it's not. We did discuss this, as I said. We did discuss should we make the values explicit, and if we did, how can we choose values that carry through the whole document? And I believe it was we succeeded in this. And so and why these values and not fairness, justice, solidarity, autonomy? I think that fairness and justice and solidarity and some of the other values too are included somehow in the values. They have a different name, but special attention to the worst off deals with solidarity. So it's not that we chose these and then the other ones are excluded. Yeah. So and then yeah, first to Sigur, just that may be a critical comment. You said that the groups that or the things that are sacrificed most by infection prevention, that's economy. But I think that the pandemic so far has shown that there are so many other values and goods that are sacrificed from the measures that has been laid upon the public. The young people, the weak ones in nursing homes that die alone, the people that don't get to see to share the last days and moments with their loved ones, the closing up of anxious old people who don't understand anything, the drug people who are dependent on drugs. There are lots of other things that are sacrificed if we let by the pandemic, and we need to lift up those two and not focus only on economy. The occupation, of course, that's a political issue too. Why healthcare personnel? Why not teachers? Why not policemen? And why not the king and queen? And we didn't see that as our job to go into those issues. And finally, thank you very much for lifting up the international perspective. I think it cannot be overstated how important that is, and how the pandemic is not dealt with until we find a way to help the people most at risk. We are one small world, and in a way it's kind of embarrassing. I agree on that we are sitting in the rich part of the world with lots of space to isolate ourselves, and we have everything, and then we in addition get the vaccines. So I think that's maybe the most burning issue of this in this discussion at all. So thank you very much for that.
Yes, I think we have. I think I'll give an opportunity for Helena or Sigur. You'd like to comment, and then we have some information at least on our chat.
Okay, I will just thank you both of you. This has been very enjoyable, and I've learned a lot. Just one quick reply to Reidun, your comment on the economic harm, and I fully agree with you that about the importance of the other kinds of harms of isolation, for example, and then there can be, for example, just psychological difficulties, and just the burdens of isolation are not the least for people so elderly people in nursing homes and these sorts of things. My question was mostly about what kinds of benefit would fairly compensate for these burdens, and whether it's a vaccine or whether it's something else. I mean, that's sort of what was also, but I was also not thinking that maybe it was not clear whether this also was supposed to refer to people in the travel industry, for example, who have lost a lot of money and therefore should get a vaccine as a compensation. That seemed to be the false kinds of compensation. Yeah.
Yes, sir. I was very happy to hear the answer, so I don't actually have a comment on that, but may I make an extra question? Because in the report and in the speech, you kind of put together the risk groups and the old people. And now when the vaccinations are coming really slow, at least in Finland, there has been a lot of discussion which one of these two should be first? Should we first vaccinate the old people or the people in the risk group? And in Finland, the old people are put first, and some people have been really critical about that. So has there been discussion on that in Norway, and how we are proceeding regarding the priority between these two risk groups?
I'm not aware of any public discussion. I guess it has been among professionals, but I had a question yesterday from a journalist who asked me exactly the same question. What about a 40-year-old man with cancer and small children at risk? Why shouldn't he get the vaccine before an old person in a nursing home? And I can't, it's a good question, and I don't have an exact answer. I think that it's a difficult prioritization, and it's more, I think philosophy cannot help out here.
Yes, I agree on that. It's interesting to hear because the situation is not similar in Finland. There is a public discussion on this particular issue at the moment.
Yeah.
I think we have from in the chat we have some information, a tip from Eli. She writes that New Zealand they had a similar a working group that proposed an ethical framework for resource allocation, and that was in June 2020. So they were early out. I think we should we need to wrap it up. I have a couple of slides to some information at the end. This is an ongoing webinar, and it's right now it's without end. So one say that let's hope it will end one day, and that we will in the near future can address like lessons learned, etc. But here you see the plans for at least 2 more webinars, and there will be more. So the next one will be with a talk from Iceland that will be in March. And then the next one will be from a Danish perspective, 21st of April. And then at the 2 bottom, there are listed another 2 topics that we work on. One is ethics of artificial intelligence in healthcare and research, and the other one is ethics and climate change. But those for now are without a specific date. I recommend you to go on Nordic Committee on Bioethics web pages. There you can sign up for the newsletter, and you will get invitation and information on future events. And this is also the place to register for events. One more thing is that the previous events, not only in this series, but also other conferences, you'll find them on our YouTube channel. So then I would like to finish off with thank you, especially to the Reidun Førde keynote speaker and the commentators. I'd also like to thank the working group that has put together this webinar. Anna and Marianne at Nordforsk, and Jonas Lundvold at Startup Norway, which has been our technical backup. And of course, everyone that followed this stream. With that, goodbye for now.